This is a talk of how to use the QUADAS, a critical appraisal instrument for diagnostic studies. Remember that critical appraisal of any study includes three elements or questions. One is for us to determine whether or not the study is valid, which has to do with the contents of the study and how it was performed, but not the results. A second separate question is, what are the results? And then the last question is, can I apply these results to my patients? The QUADAS is meant to answer the first question and the third, but not the question of what are the results. So that'll be dealt with separately. In particular, the QUADAS was developed for systematic reviews as a way of grading studies so they can be compared across different studies that were performed on the same topic. And in particular, it's interested in determining the risk of bias due to problems with validity or the methods of the study. And understand that in this particular case, what we mean by bias is that the results will actually artificially inflate the sensitivity, specificity, or likelihood ratios associated with the study, suggesting that the study performs better at ruling in and out the condition than it actually does in clinic practice. So the first domain or questions that they ask you to focus on have to do with patient selection. And what's going to happen is they're going to ask you, they're going to give you particular questions, then they're going to ask you to rank those questions as either adequate or good, so smiley face, or it's clear that they're not good, that's a sad face, or it's unclear, and that would be your ranking. So it's an all or none kind of ranking. And for patient selection, they're really asking you to focus on three different questions, where the optimal is the first question. If you answer yes to the first question, you have to answer no to the second. And then a separate question, though, is even though you may answer yes to the first, you also have to answer a yes to the third, okay? Because you don't want inappropriate exclusions. So let's go through each question and then give an example. So the first question is, was a consecutive or random sample of patients enrolled? So the optimal design for diagnostic studies is a consecutive group of patients that have similar conditions that compete for the diagnosis. So we can see here in this particular study on something called the Thessaly Test for meniscal tears, in the methods section, we find a statement that's in quotes here that states patients with suspected meniscal tears referred to a hospital for arthroscopic surgery were eligible for the study. And essentially, they were collected on consecutively as they came in until the number of patients was met. And so this gets a yes, and so we get a smiley face because this is the optimal design. It includes adequate heterogeneity in terms of other competing diagnoses and doesn't make it too difficult for us to get patients one after the other. So the second question has to do with study design. And this is an important question because if it is a case control study, it automatically means that patients weren't collected in a consecutive manner, and it's a lower level of evidence likely to inflate the results. This answering yes to this single question means its results should be taken with a grain of salt. Here's a good example for the same exact test, the Thessaly Test of meniscal tears. We have 213 symptomatic patients with knee injuries who were examined clinically, had magnetic resonance imaging performed, and underwent arthroscopic surgery. Were compared to, and that was one group, and then a second group was 197 asymptomatic volunteers who were examined clinically and had magnetic resonance imaging done of their normal knees were included in this study. So we can see clearly here now there's two groups of patients, and the two groups of patients suggest what they're doing is limiting the amount of competing diagnoses that the test has to work against to make the diagnosis of meniscal tears. And essentially, it's known that in one group, all the patients have meniscal tears, and it's known in the other group that they have asymptomatic knees. So this is a good example of a case control study, which is likely to lead to artificially high sensitivity and specificity values. Now, another kind of error that can occur has to do with, did the study avoid inappropriate exclusions? So essentially you want a lot of competing diagnoses to be associated with the sample of the consecutive patients that you admit to a diagnostic study. However, if you have too many exclusion criteria, then essentially what you've done is made it so that it's easier for the test to perform well, since everybody in the sample likely has the condition in the first place. And so this is an example of an article done on shoulder problems where they're looking for diagnosing biceps tendinopathy. And we can see here there's a long list of exclusion criteria. So disorders of the shoulder prior to surgery, including clinical arthritis, pseudoparalytic clinical presentations, fractures, labral pathology, infection or surgery to the affected shoulder. So this may be an example of exclusion criteria that are too many to make it the sample useful or comparable to other competing diagnoses that you may want clinically, especially the labral pathology. So it's typical for us to try to distinguish between biceps tendinopathy and labral pathology. So that covers questions about the sample, and so you would rank each one of those, and it's clear that you would want the first question to be answered yes, and the third one that no, there's not inappropriate exclusion criteria. And given those two, then you would have a high-level study. So the second set of questions have to do with the index test, or this is the test that you're interested in proving or understanding its efficacy or errors designed with applying it in the clinic. And so could the conduct or interpretation of the index test have introduced bias? So is there some way that they're performing the test that biases the results somehow? And then we have two questions for that. And the first question has to do with where were the index test results interpreted without knowledge of the results of the reference standards. So this has to do with when it was administered, did the person who's doing the test, did they have knowledge of the gold standard before? And that's obvious, because then they would know, they wouldn't be blinded to the actual study results. And so you'll usually find a sentence in the text somewhere. In this example, they're trying to use the Lachman test to diagnose ACL deficiency in patients with OA prior to total knee replacements. And we can see here that perioperatively all patients had a Lachman test performed on physical exam by the senior surgeon, and this is before the reference test was applied, which was done in arthroscopy. So that would satisfy the blinding requirements of this question. And we have this next question that has to do with if a threshold was used, was it pre-specified? So oftentimes, in order to categorize somebody as diseased or not diseased, you use some type of threshold. Like, for example, here's if we're going to classify people as at risk for falls or not at risk for falls, we might use the timed up and go test. And the timed up and go test, we have several options for categorizing, because we basically use a stopwatch. We ask the person to stand up, walk 6 meters, turn around, go back, and sit back in the chair, and we time that performance. And so the average times for healthy people are around 11 seconds, and then it gets progressively declines or it gets longer as people have lower functional ability. But where that cutoff gets drawn to decide falls risk is an open question. And so if it's pre-specified, then that's good, and it gets a smiley face. And in this example, in this article by Christensen from Physical Therapy, what they did is they predefined tug scores at less than 30 seconds as no risk, so they're faster, more able, and higher than 30 seconds as at falls risk, because that predefined level was a positive, and then that strengthens the study and decreases the risk for bias. So we have some similar questions about the reference standard itself. We want to understand how good the reference standard applies to our question or the diagnosis that we're trying to make. So the first question is the reference standard likely to correctly classify the target condition? So essentially, this is just, is it a good reference standard for what we're trying to diagnose? And in the examples of the meniscal tears, you have a couple choices. You could try to use imaging, or you could use arthroscopy, where you actually observe the knee during surgery, right? And what's interesting is that MRI misses a few meniscal tears. There's certain types of meniscal tears MRI doesn't pick up. And so the choice of MRI would be okay, because you'd pick up some meniscal tears for sure. But it's better gold standard arthroscopy, where you actually observe the test. So the choice of gold standard matters, and it can influence the accuracy of the results. So in this case, with the meniscal tears, it's better to have arthroscopy. So example 2 is where the reference standard results interpreted without knowledge of the results of the index test. And so this has to do with blinding again, and we know that if they know what the index test is before, but then they go to look at the person's knee, they may be biased to try to make them match. And so here in this study about the Thessaly Test again, we see that magnetic resonance imaging scans were evaluated independently by one experienced radiologist and one research fellow in the musculoskeletal radiology. Both of them were blinded with regard to the results of the clinical test. So we oftentimes can find a sentence in there being specific about whether the examiners were blind to either the clinical test or the reference standard. And having them blind to both is the best. And then here's another example about just how the actual clinical test is performed and how that matters. And we expect the clinical test to replicate the clinical situation that we use it in. And in this particular example, where they're looking at the Lachman test for knee OA and determining whether the ACL is intact prior to total knee replacement, we noticed that in reading about how the test was applied, the examination was performed after induction of anesthesia and before incision, at which time an anterior force was applied to the posterior aspect of the tibia while the knees were flexed. So the key here is that the Lachman test is applied under anesthesia. And normally for treatment planning of total knee replacements, it would be more beneficial if the test had been performed in a clinic situation, not under anesthesia, because that was what would actually help us with planning and might reduce the need for an MRI. So this is a negative, and you need to watch out for this kind of thing in some of the studies when you're reading how the tests were actually conducted. Then the last part of the validity question has to do with flow and timing. Could the patient flow have introduced bias? So let's walk down the 3 questions identified here. So the first question was there an appropriate interval between index test and reference standard? So it can be, for convenience's sake, you might have something where you apply the clinical tests and then wait for the person to have surgery to apply the reference standard. Well, it could take, for orthopedic surgery, it could take a couple months or several weeks for someone to have the arthroscopy. So there's always a chance that the status of the person changed from the time the test was, the clinical test was administered or the index test was administered, and the gold standard was applied in that case. So it's important to understand the interval between when the index test was applied and when the reference standard is applied, so that you know that the status of the patient isn't actually altered. And so we find a sentence here in the article about the Speeds test on tendinopathy that all procedures were performed on the same day as the clinical assessment by a single surgeon who was unaware of the results. So then they also note the blinding. So the second question in patient flow section is, did all patients receive the same reference standard? And here I found an example where they did not. And this experiment had to do with a prone Lachman test. So the Lachman test can be difficult for people with small hands to perform, and there's an advantage of performing it prone and for people who do have small hands. And so this was a recent article in 2011 evaluating the accuracy of that. Well, for 15, here we find that for 15 patients, this gold standard for diagnosis is direct arthroscopy arthroscopic visualization of the ACL. For the other 37 patients, they didn't have direct visualization. So in other words, they were unclear whether they had an ACL injury or whether they were going to opt for surgery. So they weren't undergoing an arthroscopy. So they decided to kind of try to include them anyway. And so they had two groups of people. So in this particular case, this is a form of verification bias. So in one group, the 15, they're using arthroscopy to verify the presence or absence of the ACL. And in the other 37 patients, they're using some other technique. And so in this case, you have basically two gold standards being applied to different decisions that are being made. And likely there's going to be more negative findings in the 37 patients who aren't going under arthroscopy and more positive findings for the 15 patients who are undergoing arthroscopy. And that's why it's called verification bias. It's biased toward the gold standard is better for the people who actually have, or it's verified that they have the problem. The last part in patient flow has to do with where were all patients included in the analysis. And what's nice now is all articles are required to have a flow sheet or flow chart like this, and we can see that essentially there were 602 patients that were possible. A few got excluded, many got included in this particular study. We can see that 3 people, they just couldn't keep track of their numbers. And then there were several positive, several negative tests, and then finally other missing values. And so overall, when we were trying to evaluate the amount of dropouts and missing values, and if the dropout rates are less than 5 to 10% and the sample's fairly large, well then the assumption is that they were really not biasing the results very much and we can trust the findings. If they're higher than that, then it becomes an issue of how we take that into account. Okay, so those questions have to do with validity, and now they would having assembled like smiley faces so that we approve of them, or they don't meet our standard. We could count how many were positives and negatives, and then we could skip to this section on applicability, right? And so this has to do with the third question, and we have of can I apply these results to my patients? And so basically the QUADAS divides this into 3 areas: patient selection, some concerns about the index test, and then concerns about the reference test. So let's see what their questions are and think about examples. So the first area is patient selection. Are there concerns that the included patients and setting do not match the review questions? So in other words, the review question here, you could think of it as your clinic situation. So one of the things that's clear is that the spectrum of patients matters in terms of the success of diagnostic tests. And so it may be obvious to you that people with more severe injuries, it's easier to diagnose the condition than people with less severe injuries. So the severity of the sample matters, and what you want it to do is match your severity of patients that you see clinically. Also, the number of comorbidities that patients have can also make the diagnosis more difficult. So for example, if you work only in a foot clinic where all of the feet you see have a variety of problems like diabetes and this kind of thing, those comorbidities may make it more difficult to diagnose tendon problems and things like that in the foot. And so what this is getting at is that it's really typical that different settings matter in terms of the success of a clinical test. And so it's typical to see diagnostic validity studies repeated on a variety of patient samples to affirm the idea that the test works across a spectrum of patients that is relevant to you clinically. So oftentimes it's important to note the spectrum of patients that the study's being conducted on, and then ask the question whether a sample of less severe or more severe patients, or patients with less or more comorbidities, or a different setting might be appropriate for your application in your clinic. So the next thing has to do with the actual index test. Was it performed in a way that's similar to how you would use it clinically? And they word it this way: are there concerns that the index test, its conduct or interpretation, so how you do it or how you grade it, differ from the way it was done in the study? So for example, if you need special equipment or a technique that requires special training, I guess you could use the prone Lachman test example here, where if you'd never learned about it before, then just immediately using it's probably not likely. That you probably have to do some training and understand hand positions and things like that prior to using it clinically. And so that would be just an open question for you to think about. The last one is kind of interesting. It has to do with whether the reference test is matching what you are concerned with diagnosing clinically. So are there concerns that the target condition as defined by the reference standard does not match the question? So a good example of this, some things are hard to match, like subacromial impingement syndrome is really not a pathologic state. It's a state where the tendon becomes inflamed because the tendon's being abutted against the underside of the acromion. So given that its imaging doesn't really diagnose it, it can diagnose inflammation, but it may not have been irritated and then might not be reflective of the condition. So coming up with the gold standard for subacromial impingement syndrome has been challenging. Another example is maybe more concrete is how we define studies of falls risk. So many times we ask people questions about how they fell, and we consider falls that are defined as a fall to a lower surface as a fall. But we could also define it slightly differently and say a fall to a lower surface that resulted in an injury. That's a different way of defining it. Both ways have been used, and depending on your question, whether it results in a fall or not may be more relevant, or just an injury that causes someone to have fear, maybe that's more relevant to your clinic situation. So both are valid, but they're going to lead to different results in terms of the validity of the tests. And so matching the reference test to your interest clinically has to do with applying it to your patient groups. So what we can notice is that the questions on applicability are more contextual. And so whether you apply a smiley face or a disfavorable face or frown depends on your patient, your clinic situation, what patients you see, and how you're using the tests clinically. Finally, here's the final results. So essentially, this is an example from the QUADAS 2 website where we can see that the categories or domains of the questions related to the QUADAS 2 are detailed in the columns here in the top, and then each study is listed here in the rows. And you could look here quickly and say, well, study 1, they had good patient selection, their index test was adequate, the reference test was good. However, in the applicability, there's some bias introduced in terms of the spectrum of patients, but the indexes and the reference standard are good. So that would get a 9 of, or let's see, 1, 2, 3, 4, 5, 6 of 7 as positives, right? And a less good study, we could do study 3 here. It only had really a good reference standard and good flow. There was some good application, but there were real issues with patient selection, the description, and how the index test was applied. And so this way we could kind of compare different studies, and we would, if we had 2 studies on the same procedure, we would trust study 1 more and expect study 3 potentially to have inflated sensitivity and specificity values because of issues related to validity. So this is just a quick review of the QUADAS 2, what the criteria are and how they're applied. I hope this is helpful to you.